There we go. Thank you. So welcome back to everybody in the room and welcome back to everybody online on the Zoom. So we're going to start with our next presentation. And I'm going to introduce Mandy Smith. And I think we need to go back a couple slides, please. There we go. There you go. And
I my fingers. I get it. I totally get it. I do that every presentation I do. So no worries.
so here we go. Mandy, I'll turn it over to you.
Great. Thank you, Carmen. Thank you all for attending today online and in person. Really super excited to share these things with everyone today. What we'll do is I've got a couple of presentations. The first one I want to do is the risk reduction and recognition for clinical healthcare staff. So basically what we'll do is we'll go through recognizing risk of transmission to any transmissible organisms and identify the infection control practices that you would utilize to mitigate or reduce those risks. So risk recognition, next slide, is seeing the potential for a problem to happen, and that's directly from CDC Project First Line. I think that one didn't end up in the slide deck. We've been, yeah, this is fine. We've been working on these right up until the 9th hour here, guys. So again, you know, this is kind of nursing stuff, stuff that we all learned as newbie nurses. But when you become an infection preventionist, it really is your foothold to know that chain of infection. And part of the chain of infection is your reservoirs in healthcare. So you need to know the places where those germs are going to live. On a patient's body or inside a body, for example, skin carries microorganisms. You have microorganisms in your gut and respiratory tract, in your blood. You get them from the environment as well, from wet surfaces, from dry surfaces, from dust and dirt, and from other devices. Another step in that chain of infection is a pathway. And the pathways through which infections can travel, organisms can travel, is through touch with your hands. You can breathe things in that can make you sick through splashes and sprays of water and, unfortunately, body fluids. By bypassing or breaking down the body's natural defenses. You know, our skin is a huge defense against infection. And when we're doing things like surgeries, that really breaks through that and puts you at more risk. Yeah, I don't think we're on the same slide deck.
Okay. No. Okay, we're gonna pause here. We need to change out
it's the other one.
For,
sorry about that.
Okay, online, are you able to see the slides? Give me a thumbs up or no in the chat. Let us know.
But not the voice one, right? The one that you said, not the other one.
No, it should be the, I can't even remember what I named it now. I'm sorry.
Okay, thank you, Hope, for answering. We do have to get the correct slide deck up too, because Mandy's going to be with us for 2 presentations, and the first one is part of Project First Line with the recognizing and reducing the risks, but the second presentation is going to be specific to STIs.
Right. Okay. No, that's, I thought we communicated that.
Okay, here we go. Perfect.
Alrighty. Thank you guys for all of your patience with us. So from this slide, we'll go to the next slide whenever you're ready, Manise. No, you're fine. Take your time. No worries here. So again, just as I was wrapping up there, by bypassing and breaking down the body's natural defenses, breaking that skin for surgical procedures and things like that, we put people at risk for infection. Next slide. There we go. I think we're synced now.
Perfect.
Go back to recognizing risks from patients. There you go. Yep, I think we're good now. Great, thank you. So organisms can live in the gut, the respiratory tract, blood, and on the skin, as I was saying. When testing for STIs, keep in mind there are also organisms that live in the mucous membranes, back of the throat, nose, mouth, and other mucous membranes. Transmission can happen when your skin and mucous membranes contract organisms, and transmission can be facilitated by contamination of your shoes and clothing. Not so much with some organisms, but certainly with insect infestations. Next slide, please. Okay. And so we ask that you utilize standard precautions to protect yourself. Just to mirror what Gina said, hand hygiene, hand hygiene, hand hygiene. Hand hygiene is important enough that Joint Commission Resources named hand hygiene a national patient safety goal again this year. Since I've been doing acute care infection control, it has been a national patient safety goal since 2019. So it's obviously very important. Use of personal protective equipment. We're required as healthcare organizations to give you masks, gloves, give you eye protection gowns, anything that you need to have for a barrier against organism transfer. Respiratory hygiene and cough etiquette. Utilize your face mask for droplet precautions. For airborne precautions, you're going to go a step higher. You're going to use that N95, coughing into your sleeve, those kinds of things is that respiratory hygiene. Your sharp safety, engineering and work practice controls are an expectation of a facility as well to keep you safe. That means we use safety devices. We do education that you don't recap needles. We provide you with appropriate sharps containers to dispose of those devices. And again, that flows into those safe injection practices. You're using aseptic technique for parenteral medications, and that is more of a patient-driven safety measure, but it's part of our standard precautions. You use your sterile instruments and devices. You utilize a Spalding classification for cleaning equipment. And Gina, it sounds like we sat and wrote our presentations together almost. That Spalding classification is the low-level disinfection for the non-critical devices. For the semi-critical devices, things like endoscopes, speculums, things like that, you want to do the high-level disinfection. And then for those surgical tools that you're going to use, those critical devices, you'll use sterilization practices. You need to clean and disinfect your environmental surfaces, and two-step cleaning. One is to clean, second is to disinfect. That is something that a surveyor will definitely call out your staff about, whether or not they're doing those two wipes. Using those appropriate chemicals, those chemicals that are approved by the EPA. At my facility, we do have a disinfectant work group. Anything that is brought into the hospital, be it from alcohol swabs and hand sanitizers to what we're using in our sterilization department, those all have to be approved by the committee. It's a multidisciplinary committee with infection control, safety, facilities. We just have to know what we're using and that it's appropriate. UV treatment is something that's become very, very big with COVID. Does anybody in the audience, just by a show of hands, maybe have a UV robot that they use? They're nice. They're super nice. Okay, next slide, please. Let's see if I don't use this computer very often, can you tell? And so we'll go to recognizing risks from the environment. Again, those wet surfaces and water. Gina spoke about Legionella. Dry surfaces can also hold fomites that can transport organisms to bodies. Devices, your critical, semi-critical, thermometers, surgical devices, and dirt and dust from construction and unclean practices. Where we're most likely to encounter water or wet surfaces would be in our central sterile department, anywhere that we're doing hand washing, our dietary department. Dirt and dust, again, like I said, you know, those dusty closets and those construction projects, you know, those are things that coming into an infection control world, I really didn't give that kind of thing much thought, because we wash our hands, we sanitize things, and we take care of patients. Those kinds of things never even occurred to me going into an acute care IC position. We utilize some of these graphics from NIHB's Project First Line for reminders with our EVS staff. Oh, I'm sorry. See, I told you I'm not used to having an assistant. So germs live in water and on wet surfaces. And what we're seeing, if anybody wants to throw into the chat just for fun, show off your knowledge, what we see in wet instruments and equipment, you know, what kind of organisms grow in those water and wet surfaces. So to get rid of those risks there, we need to be cleaning and disinfecting. We need to do our device sterilization according to the manufacturer's IFUs, which is information for use. It comes with every product that we buy in the medical field, and it will teach you how to take care of it and exactly what it needs to be cleaned with, so it doesn't cause damage or other corrosion or leave behind anything that doesn't need to be left behind. And again, we use our hand hygiene, we use our PPE. When you're coming into water and wet surfaces, you want to make sure that you're gowned and you're gloved, and generally have some kind of an eye protection as well. Next slide, please. And one of my big pet peeves, just to address eye protection, tech glasses are not considered PPE. So the nice fold-up plastic glasses that we all really like to use during the pandemic are not considered PPE. They're not appropriate. They need to be goggles. They have to seal around the eyes to protect those eyes, or a face shield if you can't tolerate the goggles. And I know they're not terribly comfortable, but they keep you safe. So next we'll talk about what kind of organisms live on dry surfaces. Dry surfaces can spread, oh, back up just one, please. Sorry, no, we're good. Organisms that can live on dry surfaces can be the Clostridioids difficile, which cause the C. diff infection, norovirus, Candida, like the Candida auris that we're hearing about going around. It's a nasty, nasty infection, and good old rotavirus. We see those things, they live on those high touch surfaces that we talk about. And with the pandemic, I don't think anybody knew what high touch surfaces really meant until COVID. Those are the things that get the most action, so to speak, in any room, hallway, facility, talking about those bed rails, those light switches, the door handles, the grab bars in the hallways, things like that. We, during the pandemic, actually employed one person full-time to do nothing but track around and do high touch surfaces all day long. She was our one woman COVID team. She was amazing. She was really good. So when you're dealing with dry surfaces, we need to be cleaning and sterilizing, cleaning and disinfection. Again, that two-step process. This is going to become repetitive because this is what it is. It's just these standard things in infection control. Cleaning and disinfection, the two-step process, use the once to clean it, twice to disinfect it. Your device sterilization needs to be done, and your hand hygiene, and use your PPE. Generally for those dry surfaces where we're not coming into contact with wet things, gloves and sometimes gowning, depending on what you're dealing with, do the trick. Shoe covers are also a good item to have. Next slide, please. Germs can live on devices, device contamination, and this was kind of a topic of ours at lunchtime. You know, the pulse oximeters that we share from room to room. You know, during the pandemic, we really tried to use dedicated equipment, but at the end of the day, there's only so much to go around. We all had supply chain issues. It came to the point where we couldn't get the finger probes for the oximeters and things like that. No, so we were using disposable things. You know, it came to the point where some of us couldn't get face masks. So we really had to be careful with what we were doing and become really good at finding those things that we could reuse, but we had to learn how to clean them. And so as you're going around patient care, you can run into Staph aureus and Staph Streptococcus, excuse me, Candida and yeasts, fungal growths, and gut bacteria. Again, that goes back to that C. diff, your enterobacters and things like that, that you can unknowingly spread from one patient to another just on something as simple as a pulse oximeter. Next slide, please. Thank you. And this is something that is kind of near and dear to my heart. Dust and dirt can also harbor organisms. Building construction can release that dirt and dust into the environment. You end up with things like Aspergillus, Cryptococcus, organisms that you don't generally encounter in such great quantities, but when we're knocking down walls and tearing out ceiling tiles, you really start to disrupt some things, and these things can get airborne and make people sick. With the ICRAs, my favorite statement in my facility on an ICRA is one ceiling tile at a time. And in this presentation here, I've got, these are actually batteries for our PAPRs, our purified air devices. And you see where I run my finger through the dust. That was from one ceiling tile being displaced to run a cable. So for me, one tile at a time, we don't need an ICRA, doesn't cut it for me, because that's exactly what we end up with there is that dust and that dirt. So of course you want to do your PPE, you want to do your hand hygiene, but what you really need to be aware of and in tune with is your barriers when you're doing construction projects. You want to make sure that you've got those plastic sheets up. You want to make sure that you allow for ventilation and air changes, something else we never even heard of before COVID, really. So, you make sure that you've got those in place. And again, it's size of the project doesn't matter. Got to keep those all in check. Go ahead and go. Let's go next slide, please. So here's something fun, and Moonies, I'm going to ask you to help me here a little bit. I've got a couple of pictures here in the presentation, and if anybody in the audience, online or live, wants to tell me what is the risk here that we're putting towards our healthcare workers. Can we bring up the chat here?
Yeah, we kind of get.
Gina, everybody's shy. Do you want to throw something out? Right, that's a construction site that was put up. We had a water leak, and so we had to replace some drywall by our cafeteria. And so the thinking went with our facility staff, well, it's not a critical area because it's not by patient care. Well, we all eat from that cafeteria. So no, it wasn't much of a risk to a patient. However, it was risk to our staff. Our staff can get sick just as easily as our patients in the beds can. So yeah, that definitely needed to be sealed better.
Yeah, and Hope had the same answer too. It's not sealed.
Oh, I didn't even,
Yeah,
you're good. I didn't even see that one.
Not
Oh,
sealed
yay,
properly.
Hope. Thank you. Okay, and then this picture on your right here on the screen, how does that put a healthcare worker at risk? That's correct. That's correct. Funny story about this is this was actually an isolation room. At least one of those bags should have been red. Both of them should have been red. And yeah, this is one of those things that's kind of one of my pet peeves. It's like being at home, isn't it? It's like, how much more stuff can we shove in here? We're all human at the end of the day. We all do the same things.
Sorry to interrupt. Do we want to rename from me to you or?
Oh no, it's fine.
Okay.
It's fine. I just figured we just read from the chapter.
Okay.
If that's okay.
Yeah.
All right. Okay, and then we'll go to the next slide, and we'll just kind of keep looking for these things. What are we seeing here? This was from my same isolation room. This yellow cart here. And again, to kind of call out what Gina had said. That thing is overflowing. It should be closed. They actually have automatic closes on them so they don't remain open to have that material jostled around or do anything to disrupt anything that might be on it. One of the things when we go through infection control training is that you learn that you handle and disturb linen as little as possible because you don't know what's wrapped up in it. That
Food. Is it food?
it's food.
Food.
Yes.
Oh.
These two pictures to the center and the right there are all I had taken a couple of pictures and I kind of had to edit these down because if I showed the whole picture, there's patient information. Somebody was just having a bad day because they left their patient information up, which is a huge HIPAA violation. And then in addition to that, they've got personal belongings sitting here right at the nurse's station on the floor. This white bag here in the center, sitting next to the 2 drink cups right at the nurse's station. They've already had their drinks. It's an infection control standard practice that you don't eat or drink in a patient care area, which this nursing area is. It's right in the middle of an ED bay or an ER bay, however you guys term it. And not only is it an infection control standard, it's an OSHA standard. So if OSHA came in and saw that, they would cite us for that because we're not doing a good job of putting measures in place that our workers are not at risk. And with the personal belongings bag sitting there right at the nurse's station, as you can tell, this is just tied up in those patient belonging bags that everybody gets. At our hospital, we actually have a standard. Any patient belonging should be tied in an overhand knot or a gooseneck tie, so that no open spaces, not even a little hole is available. And the reason why we do that is for bed bug control. We've actually had to shut down entire rooms due to bed bugs. It's just kind of one of those things of life, how lice was big 20 years ago, now it's bed bugs. And so we have those practices there. And the way that this puts my nursing staff and my CNA staff and my EVS staff at risk is that those bed bugs can crawl out of there and jump on, not jump because they don't jump very far, but they can fall out of there and land on somebody's shoe or clothing and they get taken home with them. And that is just a miserable experience. It's very expensive to get rid of bed bugs. So those are the kind of things that our staff unwittingly puts themselves at risk for. And those are the things that I take care of and take a look at. Other things, we put specimens on the countertop and we don't think about those kinds of things because we've just wiped it down and we walk away and we don't wipe it down again. I foamed on the way in. I was only here for a second. It doesn't count. Those kinds of things. And those kind of things all do count, especially when you have very infectious organisms like C. diff. A second like that does count. I lost track of what I was going to say next. So I'm going to take a sip of water here real quick. I only half jokingly tell new employees when they come through their infection control orientation that it's literally my job to keep them safe, whether they want me to or not. And so that is something that I kind of live my life by. It's about our patient safety first, our employee second is first and a half, because it's just as important to have people there and well to take care of our patients as it is to have patients in those beds. And I think that is everything on this presentation. Any questions? Oh no, I've got my reminders. PPE only works if you use it. And you have to use it, next slide, Winnies. It only works if you use it correctly. I had a young man that was going into an airborne isolation room the other day, and he came to me and he asked me, should I gown to go in here? So we discussed, yes, you need to do this. Yes, you need to do that. Make sure you put on your respirator. Okay. Good kid. Very nice young man. And I just felt something a little weird about that. So I went to check on him to see how he was doing with cleaning this room. And I noticed that he was getting ready to walk into this room with a face mask on. Stop, time out. There's a huge problem there. And I asked him, I said, well, do you have your N95s? Did they have them down in the EVS department? And he says, no. So I thought I'd just put on like 3 of these. And that's, I get it. It makes sense. Kind of. But no, we stopped there. We did just-in-time training and we found him in N95 before we sent him into the room. So no, and more is not necessarily better. Putting on PPE that you don't need to put on. So you put on a face shield to go in and clean up a blood spill on the floor. It's not necessary. It gets in the way. It can actually make things worse to keep you safe. So yeah, I understand the thought and the inclination to want to put more PPE on, but it's not necessarily the best thing to do to keep you safe. Exposure can happen if you're only in the room for a minute. That's one of my big things. And we see staff, and it doesn't matter who the staff is. It could be admin staff coming in to check paperwork, or it can be our chief of medicine going in to talk to a patient. Everybody has that mentality. It's like the organisms or the germs or the bugs aren't that fast. So if I'm only in there for 3 seconds, they're never going to catch me. Not true. I know that donning and doffing, putting that gear on and taking it back off is really horrible. And it's really hard to do sometimes until you take C. diff home. And then you will remember to don and doff for the rest of your life. Yes, Gina. Mm-hmm.
Most of the time, the problem is the ES staff don't know there's a patient in isolation, or they don't want to don their PPE.
Right.
So.
Right, exactly. And we've got policy that kind of speaks to that, where we do, and it was something that I brought with me from another hospital, is where we do the handoff of linen and garbage at the door. So the nurse has to go in there to take care of the patient anyhow. So they are to, get those bags together and hand them off to EVS at the door.
Yeah, and the comment in the room was that a lot of the time of talking back about the previous picture in the isolation room, that the EVS staff didn't know that there was somebody in isolation, so that can lead to some of the slip ups of not doing it correctly. I mean,
Yeah, thank you. I'm forgetting not everybody can hear Gina like I can hear Gina. So yeah, and just another reminder to wash your hands. We can't say it enough. And to put a fine point on Gina's presentation, don't touch your face, which is something I'm working on very, very hard. I timed myself yesterday. We had Dr. Holt that was presenting, and I thought, just for fun, just so I can share this with the rest of the group that we're presenting to, because none of us are infallible. We all have our little things. I sat and counted how many times I touched my face yesterday during Dr. Holt's presentation. It was 18 times.
wow.
Yeah. So 75-minute presentation, I touched myself almost 20 times. It's a little embarrassing, but it's something that I work on. Your isolation guidelines can be found on the CDC website. There is a 240-page manual as to what we do for isolation per the CDC, and that link can be found in the slide deck. I like to use it a lot. It's really nice, quick reference if we need it for things that walk through the door that we haven't seen very often. And again, Project First Line provides infection control resources and training to keep patients and caregivers safe. All of the wall signs that I've shared here today are all Project First Line handouts and what do I say, media that we can share. So yeah, they're a really good resource. Alrighty, any questions?
Yeah, so the question in the room was about the PowerPoints, if they'll be shared. They will be shared with everybody in the room. We'll get we can email them out, but they'll also be available on the webpage that I mentioned when we can send that link as well. Do you have the link to the hub? Do you have the link to the hub to put in the chat?
And then I did try to make hyperlinks out of all my resources too. So
Yeah.
just a click away. Okay. Get out of that one. And
So how's everybody feeling? Do you want another quick little break, stretch, get something to drink, or should we just move on to the next one? Just keep going?
Alrighty.
Okay, let's keep going.
Alrighty.
Sounds good to me.
Give me Just a second to load up the
Okay.
next slide deck.
So,
Yeah, the STI one.
so we'll transition to the next slide deck so that concludes the presentations that we have that are that have to do with the Project First Line and the infection control. We're going to stay with Mandy for a presentation on the screening and treatment of sexually transmitted infections.
All righty. My niece is kind of getting everything together. You know, our learning objectives today, what I want to hope to make clear for you all is the identification of syphilis and other bacterial sexually transmitted infections. We're not going to cover the virals or anything like that. And
Are you sharing that on Zoom? We're not seeing it. Yeah.
that's okay. That's fine with me. So yes, identifying those bacterial STIs, which are sexually transmitted infections, STI, STD, the D in there is disease. It is used interchangeably nowadays. I know we had a push a few years ago to call those STIs, and it reduced that stigma a little bit of having those infections. But not everybody has caught on to that. There's still a lot of literature out there that calls it an STD. So if I'm back and forth between those things, I'm talking about the same thing. But I just kind of forget myself sometimes. So we want to be able to identify those things using symptoms, history, and testing. We want to be able to be comfortable with the treatment of chlamydia, gonorrhea, and all syphilis stages, and recognizing the risk of STI being transferred to a fetus, congenital infections, and be able to identify your risks when testing patients for those STIs. I think we're getting there. A little bit about myself, since I skipped over that with the last presentation. I can't say anything. It says end of slideshow, click to exit. That's okay. I'll just keep talking for a few minutes. I am the infection control officer at 12 Clans Unity Hospital in Winnebago, Nebraska. Winnebago is about 35 miles south of the Iowa, South Dakota, Nebraska area, that tri-state area. We have a lot of urban Native Americans that use our hospital services. We are right next door to Macy, Nebraska, which is home to the Omaha tribe of Nebraska. That's still not the right one. Yeah, it is. Yeah. So Winnebago is home to the Ho-Chunk tribe, originally of Wisconsin, and they traveled during the 1800s to where they're at now. They've kind of lost members along the way. There are Ho-Chunk tribes that are all the way from here back to Wisconsin. Some have traveled a little further west of us and a little farther north of us. So there's lots and lots of people that we do see. You know, they'll come back for their health care at Winnebago, which is really kind of nice because we get to see a lot of different communities and how communities really kind of make up this whole Ho-Chunk tribe. So it's kind of a neat little situation to be in. Yep. And so we'll go ahead and go to the Muniz is right in the spot that we want to be in, and we'll get down to business. Enough about me. So 2019 marked the 6th consecutive year of record-breaking STD cases in the United States. Starting at the beginning point in 2014, where this graphic is, it increased steadily at about 100,000 cases per year prior to the pandemic of 2020. And that's when the data kind of stopped. We are still in the process of compiling it. So, you know, our most recent graph is this up to 2019. And for all STDs in the US. Great, thanks. So sorry. All right, we'll just go ahead and go to the next slide. So this graph is the weekly reported US STD cases from 2020 versus 2019. So on the left-hand side of the graph, you've got your percentile, and that's kind of represents what went on in 2019. And our data goes across all the weeks of the year of 2020. And as you can see, we have that great big sharp decline at our data point of the COVID-19 national emergency declared. Now, there are different schools of thought as to why that huge drop happened, whether it was people were social distancing and they weren't being exposed to STIs, or if it was because they could not get into clinics to be tested for those STIs. And if you look at this graphic, you know, you kind of follow it along through the spring and the fall. And in September, we thought that we were going to be okay with this. The numbers declined a little bit. And so we opened things back up. The lockdowns ended. A lot of the public health measures had expired at that time and were not renewed. And we had a huge spike again. And the other thing that spiked at the time was COVID. And so we locked it back down again. And so you see those numbers decline again real sharply in September, but they came back and started slowly increasing again over the rest of the year. The one sexually transmitted infection that really did not make a big comeback and did not exceed their 2019 numbers was chlamydia. I have not found any data that explains why that has not been increasing like the other infections, but that's what the data shows. It's kind of crazy. Let's go ahead and go to the next slide here. And we'll talk about syphilis. Syphilis is a emerging problem all across the United States. I know in our Great Plains area, or GPA, this has been a huge topic. We've had really big outbreaks of syphilis, Pine Ridge, Rosebud, Winnebago. Prior to this outbreak this past year, I had never worked with syphilis. I'd never seen a case of syphilis. There was a time in the early 90s we thought we had it eradicated. We were wrong, obviously. So here we are learning about syphilis again. And this has been kind of a learning experience for everybody that I know in the nursing profession that I work around and work with, because it has been just so uncommon. And we're a teeny tiny town in Nebraska. So we just don't have the numbers either to really make a showing. I will warn you as we go through this slide deck, there are some graphic photos of syphilic chancres. So I just want everybody to be aware of that. Know that you can close your laptop or turn your monitor off for a couple of seconds if you need to. But we'll discuss primary and secondary syphilis here. And again, this is the difference compared to those 2019 STD cases. And this is just another graph that shows how sharply everything declined at those lockdown points at, you know, March and early October, late September. Go ahead and go to the next slide, Moniz, please. And so what syphilis is it's a spirochete infection. It's the organism Treponema pallidum. We transmit syphilis by vertical and horizontal transmission. And what vertical transmission is from mom to baby. So vertical and any kind of transmission is from one generation to the next. And so with syphilis, it's mom to baby. Horizontal transmission is most common, obviously, is sexual transmission. And is still treated with good old penicillin, thank goodness. And there's now 4 stages of syphilis as classified by CDC. It's not anything new in the way that it presents, it's just that we talk about it differently. We have early syphilis, we have secondary syphilis, we have latent syphilis, and then we have latent syphilis. And we'll go through those terms here in just a second as we go through the slide deck. Go ahead and go to the next slide, please. So we'll start off with obviously primary syphilis infection, the incubation period. So the time from when you're exposed to syphilis to the time where you may develop a chancre can be anywhere from 10 to 90 days. It's a big incubation period. A presentation is with a chancre, which is a small painless ulcer. And that can be anywhere on the body that has been exposed. We have oral chancres. We've seen obviously penile and vulvar chancres, intravaginal inside the vagina, and rectal chancres. They can just kind of sprout up anywhere. It usually resolves on their own, or they do resolve on their own, and that happens about 4 to 10 weeks after the appearance. So it's not a sore that only lasts a couple of days and then it's never seen again. It sticks around for a little while. Next slide, please. And here are examples of what chancres look like. These are a real standard presentation of a chancre sore. This top left, it's actually lettered A, is the inside of a lip. And it's a very, very light chancre there. It's, you know, you really have to use your assessment skills and be looking. Here we have syphilis on the tongue and another small chancre on the inside of a lip. And these on the bottom are again, the more common, where we would look for chancres in the sex organs, the penises and the intravaginal. I'll go ahead and go to next slide. One place that we don't think to look too often for most STIs, even though they can hang out there, are in the back of the throat. And so you want to go ahead and when you're looking on the inner lips and things like that, go ahead and check the back of the throat, monitor those symptoms, really take your patient's history as to what they're sick with. You know, a lot of times we get people that will come into the ER and, oh gosh, I have a sore throat and a headache. And can you check me for chlamydia too? Those kinds of just it happens at our ER. That's where you really want to take a second and explore that sexual history, the exposure history with your patient. And do they really have a sore throat, or did they just say they had a sore throat at the reception desk because they didn't want everybody behind them in line to hear what they were there for? So history taking, especially with syphilis, is very, very important. Next slide, please. And then after that primary stage of syphilis, you get secondary syphilis, which can happen 4 to 10 weeks after that chancre resolves. So this is a very long protracted period here. It can be localized or diffuse mucocutaneous lesions or rashes, as we like to say. So much easier. They can be macular papular rashes that don't itch. They can be just papular rashes, and as some of us have heard, they can be pustular lesions and sometimes be confused with monkeypox. Right now in the MS in the men who have sex with men community, we're seeing a lot of people present with these perianal pustular lesions, and people are misdiagnosing this for syphilis when it's actually monkeypox. So again, really take this patient history. The one thing that I stress with my ER is you have to get travel history, really get this specific screening for any infectious disease, because, you know, just asking one question may be the difference in the route you're going to take to get to a diagnosis. In secondary syphilis, you'll also see a generalized swelling of the lymph nodes, the mucus patches in the mouth, a palmar or a plantar rash, you know, so rashes on the feet and the hands, rashes on torsos, condyloma lata, which are growths that can sometimes be misrepresented or misdiagnosed as venereal warts, and alopecia. Let's go ahead and go to the next slide. Thanks, Monique. And here's some pictures of these secondary presentations. So, you know, starting from the left and going over, you've got your foot and your hand rashes, your torso and your back rashes, your condyloma lata. Those are those real light patches that you see there in the skin. And they do look a lot like warts. They look like papillomas. And you can also have those in the perirectal area as well. That's what that bottom is. Alopecia, it can be spotty. So, you know, kind of look for those hair patterns, and you can have mucus patches in the mouth. We had a gentleman present to our clinic, our outpatient clinic, one day that just had this rash, and he'd been to dermatology, and we were messing around with it and trying cortisone creams and everything else. And what we finally found out was this was a secondary stage of syphilis infection. But it took us weeks to get to that conclusion. So, you know, just keep in mind that syphilis is a great imitator. It looks like a lot of different things. Let's go ahead and go to the next slide, please. That early syphilis, so it's non-primary, non-secondary. So this would be the stage of syphilis where you get to, you've had your chancre and that's resolved. And then, you know, you've gone through that secondary phase. So this can be anywhere from the end of that secondary phase to 12 months after exposure. And that's basically how we classify early non-primary, non-secondary syphilis. It's syphilis, and the way that you define this, the way that you can nail this down, again, it comes back to patient history taking, which is really hard for some of us because it can be very uncomfortable. So if it's been 12 months since they've had a prior RPR or a negative test, we use RPR, so I may just refer to that out of habit, and I do apologize. But if it's been less than 12 months and they've had a negative syphilis test during that time, Drina was, I just thought maybe Drina needed something. Or you can have, or if you notice a 4-fold titer increase from a previous test, you always get a titer with an RPR test. So if that is increasing, then you want to take a look at a new infection or a treatment failure. A report of symptoms consistent with syphilis within the previous 12 months, you want to go ahead and do a screening for syphilis. And if your patient that you're visiting with has had sexual contact with a known case of syphilis, or if their first ever sexual encounter was within those 12 months, you want to take a look at that as well. Go ahead and go to the next stage. Then we have latent tertiary syphilis. And this is syphilis of unknown duration or late syphilis. So this would be after that secondary syphilis has happened. And it can be actually years down the road from that primary infection. We also, if we are not able to figure out with our patients, say they haven't been into the clinic and had a syphilis test in the last 12 months, they've had sex with several partners and they don't know if any of them are positive, those kinds of things. If we can't nail down a specific indicator that this person has had syphilis or an exposure to syphilis in the last 12 months, we treat it like a late case, because it's very important, obviously, by the pictures, that if we don't treat that syphilis infection properly, that syphilis can go ahead and evolve into a late or a tertiary case of syphilis. So again, it's a stage of infection that has occurred 12 months, more than 12 months in the past. And a lot of times you will see, and this usually takes quite a while for these gummas, skin growths, I guess I'll call them, to appear. Let's go ahead and go to the next slide. So other late clinical manifestations of tertiary syphilis may include any lesions of the cardiovascular system. So you'll see aortitis, inflammation of the coronary vessels, the gummatous lesions, as were evidenced in the last slides, bone inflammation. You'll see some osteitis at times. Other sites that syphilis can manifest itself is pretty much anywhere. It's the upper and lower respiratory tracts in the mouth, eyes, abdominal organs, reproductive organs, lymph nodes, and skeletal muscle. I mean, really kind of everywhere. And they may exhibit neurologic symptoms. Now, back in the day, let's go ahead and go to the next slide, please. Back in the day, we all thought those neurologic symptoms only happened in the late or tertiary stage of syphilis. Recent information has found out that that's not true. Neurological manifestations can happen during any stage of the syphilis infection, including primary syphilis. So as you're running these RPRs on people that you think have syphilis, or if you, incidentally screen somebody for syphilis and find that they do have a positive test, you want to come back and you want to do a more thorough exam with them to rule out these neurologic symptoms. With neurosyphilis, you can see syphilitic meningitis, general paresis, which is weakness in an extremity for unknown reasons. You've ruled everything else out. Dementias, tabes dorsalis, and meningovascular syphilis, which is the vascular system inside the brain and nervous system. The tabes dorsalis morphology is actually kind of a syndrome. It's stacked with all kinds of different symptoms of this. You'll see the nerve generation in the dorsal column of the spinal cord. So it affects moving, memories, things like that. Orthopedic pain. You'll see those deep tendon reflexes, when they take the little hammer to your knee, your leg doesn't move much. That's what you'll see with that. Shooting pain, differences in your pupil reaction, locomotor ataxia. So when you're moving, you're off balance is what that breaks down to. Impaired proprioception, you don't know which way is up. And syphilis, because we had to have something for the S apparently. So those are the things that you may see, and it may be a combination of any of those things or just one of those symptoms. With ocular syphilis that has settled into the eye, we'll see the conjunctivitis and the uveitis, panuveitis, which is a more diffuse inflammation of the eye. You'll see posterior interstitial keratitis, which is something the ophthalmologist will tell you about, and we generally won't see that in the clinic. Optic neuropathies and retinal vasculitis are things that can happen when we have syphilis that attacks the eyes. Otosyphilis or syphilis of the ear, and let me just say that it's not syphilis that settles in your ear. It's just the eye and the ear manifestations of a syphilis infection. So let me get that straight. I didn't want to be misunderstood. So the ear manifestations, the oto manifestations of syphilis may be tinnitus or vertigo or sensory neural hearing loss. I cannot speak today. The more I talk, the less I'm able to, I think. And so with these neurological signs and symptoms of syphilis, generally what we want to do is we want to do a lumbar puncture and get a spinal tap and see what's going on with that spinal fluid and see just how far this infection has gone into the body. Even though they're listed here, the symptoms of oto or optic syphilis do not necessarily mean that this person has to have a lumbar puncture. If they don't show any signs of neurological syphilis, as outlined in the left side of the slide here, a lumbar puncture is not necessary, just to kind of save that step and that discomfort for your patient. It's also, another thing that we would expose them to for infection because it is an invasive procedure. Let's go ahead and go to the next slide. Serology of syphilis. This is a tough one for us to get our heads about. Again, like I said, we use the RPR or the rapid plasma reagent test at our facility. And there's a few reasons why. It's got a very short turnaround time. We get those results within 24 to 48 hours. It gives us a titer right off the bat. There are other tests out there, the FTA, ABS, TPPA, or an EIA test, which are all acronyms for other things, and I won't go into that here. We can use those, and those will give us a real fast screen and tell us whether or not this person's got syphilis, but we'll still have to turn around and do an RPR because we need to have that titer. And how you get the titer is from that rapid plasma reagent test. We have to have a specific number on the day that treatment is initiated. And so if we have to bring somebody else in, from a week past, if we let them go at the ER or at the clinic and said, we'll get a hold of you with your syphilis test, if we bring them back in for treatment when we find that that's positive, we need to repeat that RPR again. Not for any diagnostic measure, but down the road, that will give us the knowledge whether or not we have a case of syphilis that has been successfully treated. And this is just kind of how these tests are run. They're honestly pretty similar to the rapid strep tests that we do and the pregnancy tests that we do. They use the agglutinin technology, and that's how we get those done. For us, they are a send out. Again, the serology of syphilis, go ahead and go to the next slide if you would please. We start with the traditional algorithm. We have discussed at our facility switching things up and doing those specific treponemal tests first, those FTAs, the ABSs. The FTA is a fluorescent antibody test. The TPPA is a treponema pallidum particle agglutination, which is kind of like the RPR, but it does not give us the titer. And then the EIA is an enzyme-linked immunoassay. And so that's what those letters all mean as I'm rolling through this graphic here. So again, we start with our RPR, and if that RPR is reactive, what we then do is the lab that we use does an FTA ABS test. And when that is reactive, then we know that it's specifically a syphilis infection. If it's non-reactive, it's a false positive. If you draw an RPR and it's negative, then you don't have a syphilis infection at all. You congratulate your patient, you send them on their way or continue to monitor them. Usually there's a reason why we're doing syphilis screenings. And we'll go to the next slide and discuss the serology of surveillance. So as we're watching syphilis patients from a clinical standpoint, we will bring them back in 6 months. and we'll do another RPR and we'll get another titer. If we have an increase, we know that our treatment hasn't been effective, we will watch it until the 12th month. But if we have, when we're talking about a twofold increase, our titers map out on a doubling scale. So we get 1 to 1, 1 to 2, 1 to 4, 8, 32, or excuse me, 16, 32, 64, and so on. And that's how the titers are counted out. That's just a standardization that they've done. And so when we talk about a twofold increase, that would be doubled. If we talk about a fourfold increase, that would be quadrupling, obviously, and on with the map. Now, at times we will say, this titer has moved 2 titers over. So if we take, for example, 1 to 8, like we started here, that 2 titers over are 2 spots on that chain there. It's not doubling. It's 2 spots over. So it can kind of be confusing when you're talking about these increases or these decreases in these titers. So you really want to have a standardized plan on how you refer to these. Is it a twofold or is it a 2 titer increase? Because in some instances, it makes a huge difference. Let's go ahead and go to the next slide. Treatment of syphilis. Again, like I said, treatment of syphilis is super easy. We still use penicillin. It's still good. They get an initial dose of 2.4 million units of the benzathine penicillin, IM, and we have them come back in 6 months to recheck and see how things are going. If somebody has a penicillin allergy, doxycycline is appropriate. We give them the 100 milligrams 2 times a day for 14 days. Now, the little stars here that we have is that doxycycline should never, ever be given to a pregnant woman. And so we have run into cases in our clinic where we've had pregnant women present with syphilis that were allergic to penicillin. And what we've had to do is we've sent them to infectious disease for one, just to make sure that this is, what we're seeing. And then they need to be desensitized. And usually when we have to do that in our area, we send our patients into Sioux City, which is the next biggest town. And they do that at a hospital. So yeah, that's not an either or we just let it slide. These pregnant gals need to be treated. And so we have to do this. With a late case of syphilis or an unknown duration syphilis case, what we have to do is we have to do the 3 weekly injections of penicillin. It's the same dose, same route, once a week for 3 weeks. Again, with the penicillin allergy, we do the doxy for 28 days. Then next slide, we should see an expected reduction of the titer, sometimes within 6 months, but most definitely within 12 months, we should see this decrease in the titer. And that works the same way as the increases of the titer. Let's go ahead and go to the next slide. Something we may see with the treatment of syphilis is a Jarish Herxheimer reaction. It looks a lot like an allergy to some people. And what happens is when the bacteria are killed off by the penicillin, they release an endotoxin, which causes a rash. And it's kind of like kids with strep throat getting a rash from the strep. It's the same theory, basically. And so what you present with is fever, you feel kind of crappy, you generalized malaise, nausea, vomiting, chills, the rash that you may or may not have already can get worse. The nice thing about this is it's pretty self-limiting. You just treat the symptoms. It's a quick onset. It comes on within 24 hours and it's gone again within 24 hours. Of course, you want to monitor a patient for any shortness of breath, airway restriction, because that's a very good indicator that it's not a reaction that we're talking about here, but it's an allergic reaction. So you do have to monitor that. And I do try to just have people check in with us if they have any symptoms after their injections. That way we can ferret out what it is that they're experiencing. Usually the worse the infection is, the worse this reaction can be. Next slide. Okay, thank you. Just done. Pearls of syphilis testing is that no test is perfect by itself. So you have to do that 2-step syphilis testing. it's better to overtreat than to undertreat. Like I said, it takes 24 to 48 hours to get those tests back. If we have a patient that comes in that is a known exposure to syphilis, we will give them the injection right there. Obviously, you know, they're able to pin down that history. So we know when their exposure is. We're not dealing with an unknown or latent case at that point. We just go ahead and give them the shot so that we know when that RPR comes back, they're already treated. When we test people for syphilis, I really try to encourage my providers to also test for other STIs, including syphilis, hepatitis, HIV, and we also test for pregnancy. We define the follow-up plan. Another thing I'm trying to get my patient access reps to do along with our providers is make that appointment for follow-up before they walk out the door. They'll let them know what is expected for them to come back for this treatment, because even if they don't need another shot of penicillin, we want to see them back in 6 months to test for cure. With gonorrhea and chlamydia, we do the same thing, different time intervals. And of course, we have to report it to the health department. Don't forget to report it to the health department. Next slide, we'll cruise through follow-up. Like I said, serological follow-up for syphilis is at 6 months and 12 months. Treatment failure is a sustained 2 titer, so that would be 4 times increase in the RPR. A high titer syphilis that does not decline 2 titers over 6 to 12 months or 12 to 24 months is a soft indication of treatment failure in syphilis. Again, remember, you're doing the lumbar punctures with neurologic signs and symptoms, active tertiary disease where they're presenting with those symptoms that we talked about, or with a known treatment failure. Next slide, we'll hop through chlamydia. Like I said, in 2020, chlamydia did not increase over the previous year's numbers, so that was kind of encouraging to see. Next slide. Chlamydia treatment, uncomplicated ones. We treat adult and adolescent treatment is the Doxycycline, 100 milligrams twice a day for 7 days. In our clinics and our ERs, a lot of the times my physicians will go to the gram of azithromycin one-time dose because we have such little compliance with these treatments. Actually, if we're giving 1 gram of the azithromycin, though, we really need to make sure that we are bringing those guys and gals back for a test for cure, because azithromycin is not always the drug that needs to be taken to beat that chlamydia. So we do have some cases of chlamydia that are not responsive to the azithromycin. So it's very important that we get that test for cure. And we'll go ahead and do the next slide. Gonorrhea. Again, we had that slight dip and it has made a comeback. It's about 130% of what it was the year before. Symptoms of gonorrhea, the low back, the pelvic pain, testicular pain, or pelvic pain while urinating, dysuria, pus, or sore throats with pharyngeal cases, usually happen about 2 to 7 days after exposure. Just like with chlamydia, they may be non-symptomatic at all, which is why our screenings are so important. And go ahead and go to the next slide there. Pregnancy. Oh, I skipped. You're right, I'm wrong. Gonorrhea treatment is a single dose of ceftriaxone, 500 milligrams IM. And these are all per the CDC standards that were updated in July of 2021. If the person weighs more than 300 pounds, so we have to give a full gram of Rocephin. And I'm not sure that we're always aware of that. So that's something that we really need to be mindful of. If we give that smaller dose, it may not be effective. If chlamydia has not been ruled out or diagnosed, we generally go ahead and treat patients that present to our clinic or ER for chlamydia as well at the same time. And generally what we do is that 1 gram of azithromycin. Let's see here. There aren't really any alternative treatments for pharyngeal gonorrhea. So, you know, if your patient has an allergy, I would suggest an ID consult, to be truthful. So then again, we're going to go back to pregnancy. Next slide, please. And just hit those points again real hard. at our clinics, what we're doing to screen these out so we don't have congenital cases. We actually had 4 cases of congenital syphilis in our area over like a 3-month period this year. So this is something that's really important to us. We're testing for STIs at the first trimester at 28 weeks. And then we test again for these things at birth, just in case we have an infant that's non-symptomatic. We've got that treatment in place. Other testing should be done if they're symptomatic. And any fetal death that you have that occurs greater than 20 weeks into the gestation, you need to look at an RPR and get that patient treated so that this doesn't happen to her again. Get your ultrasounds done if that syphilis is contracted or diagnosed within that second half of the pregnancy to make sure that it's not already a congenital case. And if a treatment for syphilis is given 28 days before birth, it's still considered a congenital case, whether or not there's effects to the fetus. We'll go ahead and just go to the next one. During an outbreak, we test all sexually active patients for all STIs, which is just good practice anyhow. Remember, syphilis looks like a lot of other things, so just make sure you're pursuing all avenues. People can surprise you. And again, you know, the syphilis, those primary chancres may be in a spot where people don't look, and since they're painless, sometimes they don't know that they've had those. So, you know, you sometimes may have to go off the beaten path and run RPRs on people that you don't necessarily think would need one. Again, don't be afraid to treat, don't be afraid to diagnose, especially, you know, we do a lot of jail screenings, we do a lot of pre-treatment screenings, things like that. We try to eliminate those problems in those facilities by screening and treating from the ER or from the outpatient clinic. Schedule that follow-up. And unfortunately, the last thing here, and this is the most often question I get, is if a patient with late syphilis or unknown duration syphilis goes more than 9 days between that first and second, or that second and third injection, you have to start the course all over. And you really should draw an RPR so you know where you're starting at again. I think that's everything. Any questions? Did I make time? I actually had to give that whole presentation one time in 15 minutes.
Oh, wow.
It is. Oh, let's see. Probably put everybody to sleep.
No, thank you so much. That's some great information. Do we have any questions in the room for Mandy for either of the
It's a lot.
presentations? Yeah. And do we have any questions for anybody on the Zoom? Feel free to unmute yourself or type it in the chat.
Thanks, Victory. It's just from like literally A to Z.
Yeah, so the slides will be shared. And thank you, Mandy, and thank
Absolutely.
you, Gina, for your wonderful presentation. I think we're going to wind down here. I am going to start sharing some of the things that as promised. So let me see if I can shift things around on my screen so I can start putting some of those things in the chat. And I will, so. Okay. So there's the link there to the new infectious diseases hub. So that's where you can find the newly combined webpage that I talked about earlier, where you can find the Project First Line. This is the infection control resources. We share both the CDC and the resources that NIHB is creating. And and there's my email address. So if you want any questions, anything that you want us to work on, please reach out to me and infection control. And I think, let me see, I have the applications. I think if you're, everybody, thank you for hanging in there with us and bearing with us with all our tech issues that we've had. And did we have, let's see, that's not the one. So I wanted to share the application too for I don't have my folder. For those interested in applying for the scholarship. I want to see if I can put that one in the chat. Sometimes my files don't go through, so I will try though.
You can get the email address and then send it to them.
Let's see. Okay, it looks like my file is not going to upload. If there's anybody still here, will you put your email address in the chat if you're interested in the application? Otherwise, that hub is a really good resource. It is, it might be kind of buried because there is a lot of information in that hub. But if you go into that web page and look at the Project First Line tab, and it's okay. Munez, maybe I'll be able to share it. My computer kind of froze up a little bit trying to upload it. So let's see if, okay, there's the hub. No, I don't think we can do it that way. That's okay. No, we're closing in on time. Yeah, we're closing in our time. So thank you for putting your email in there. I'll make sure to send that off to you. And as well as, well, the follow-up, like I said, I'll send a follow-up email with all the resources that we talked about, and the slides and recordings will also be there. So this will conclude this session. We do have a closing session on the main link, like where we started out with the bigger group. This concludes the breakout session. So thank you again. Thank you again, Gina and Mandy. And as I said before, everybody here, most importantly, thank you for the work that you do for your tribe and keeping our tribal communities healthy and safe.